All right, so let's start with superficial face. Congratulations to Spain on winning the World Cup. So for superficial face, we're going to be going over the skin, superficial fascia, muscles of facial expression, and then all the vessels, cutaneous nerves, and the parotid gland. So basically, for the superficial fascia, it basically houses all the, muscles of facial expression, cutaneous nerves, and superficial vessels. Here's a better diagram, I guess. The big gland that we're going to be looking at as well at the end is going to be the parotid gland. We're going to be looking at the facial artery, and we're going to be looking at the distinctions between, what to focus on, what to not, things like that. So for superficial fascia, it's just a subcutaneous connective tissue layer, and all the other stuff is like kind of blah blah blah. But the only thing that you got to know is that the facial muscles insert directly into the superficial the skin, basically, because that's how we get facial expression. Then we have the muscles of facial expression, and again, they insert right into the skin. They do a lot of things, and they are mainly, controlled by the facial nerve. That's where it gets its name. And this is for the motor innervation of them. I grouped them by region. It was scalp, orbital, nasal, oral, and neck. So we can start with the scalp, and we can see that we have the occipitofrontalis. So it's split into three parts. You have at the front, the frontalis. In the middle, we have the galea neurotica. And then in the back, we have the occipitalis. So those are all the occipitofrontalis. And the frontal belly can raise the eyebrows and can wrinkle the head. This is basically what we have right here. Then we have the orbital part. And as we can see, you can go down from the occipitofrontalis, and then we have, I want to say, three main muscles. We have the orbicularis oculi, and it's split into two parts. So we have the orbital part, which closes the eye tightly, so like you close it fully, and then the palpebral part, which is just a gentle blink. And after that, we have the corrugator supercilii, which is kind of goes across. And then we also have the pressurus right over, like right under our glabella, I guess you could say. And then we can go to the nasal group. And the main thing here is just the nasalis, which just lays over the bridge of the nose. And it has two parts as well. There's the transverse part, which compresses the nostril, and the alar part, dilates the nostril. So I kind of can see them asking, what dilates the nostril? And you'll just say the alar part of the nasalis. And then there are a lot of them in the oral group that we're going to be talking about as well. So you have the orbicularis oris, which is just for the eye, how we had the circular part. We also have the circular part for the mouth. It also has two parts, but I wouldn't really worry too much about them. At least I think. I don't know what they even call them, to be honest with you. And then we have the levator labii superioris, which raises the lip upwards. We have the LLSAN, which is one that kind of goes from here all the way down like this. And some people call it the Elvis muscle. And then we have the levator anguli oris, which is a levator at the angle of the mouth. And then we have the zygomaticus minor first, then the zygomaticus major. And the zygomaticus major is what gives us the dimples if they're separated, because they kind of have like little two parts, and then you have the minor over. So this is the major, and then this is the minor. Then you have the risorius right across here. And then we have the depressor anguli oris and depressor labii inferioris. And from their names, we can see that the depressor anguli oris depresses the angle of the lip, and the depressor labii inferioris depresses it down. And then right here, at the bottom of our chin, we have the mentalis. Next, we have two more oral groups. We have the buccinator, which keeps our foods between our cheeks. And then we have the neck group. And for that, we just have the shaving muscle, which we call the platysma. And then we come to everybody's favorite part, which is the arteries. Always confusing. And I have a good diagram afterwards. So, for the arterial supply of the face, it's mainly supplied by the external carotid. We have a small superomedial zone with the supraorbital and supratrochlear, which is supplied by the ophthalmic artery of the internal carotid. That's kind of a smaller part, but we should always focus on ECA here. And then we have the facial artery, which is the big one. It's very twisty. So when we see it on the cadaver, we see it that it's super, super twisty. That's how we identify it. And it runs superior to the mandible, or from the mandible, anterior of the masseter. And then it has some branches like this superior and inferior labial, the lateral nasal, and the angular, which is the terminal nerve. Oh, sorry, terminal artery. And then we have the superficial temporal artery, which is another branch of the ECA, which gives off the it gives off the transverse and the facial artery. So there's a mnemonic, which is the branches of the ECA, and it says, some anatomists like freaking out poor medical students. And we start with superior thyroid, ascending pharyngeal, lingual, facial, occipital, posterior auricular, maxillary, and superficial temporal. So some anatomists like freaking out poor medical students. And then we go here into how they're split. So the external carotid artery splits into the facial artery and the superficial temporal. And for the facial artery, we have the superior labial, like we discussed, the inferior labial, the lateral nasal, and the angular. And then for the superficial temporal, it goes into the transverse facial. And then for some of it, we also had the internal carotid artery with the ophthalmic artery going into supraorbital and supratrochlear. And then we go to the small supermedial, zone of the face. So basically here we can track what's happening. So let's go to external carotid, which is going to be highlighted in red here. And then after that, it goes into the facial artery, which we said was the twisty thing right there on the left. And then it starts branching off from there. So we have the inferior labial, superior labial. As it keeps going up, we get the lateral nasal, and then we have the angular. And then on the other side of the ECA, we have the superficial temporal, which is superficial as it says, that's why it supplies the face. And then it becomes transverse facial. Let me see where that is. I wish I had highlighted here. And then we go into the internal carotid artery and what it supplies. So mainly supplies the ophthalmic artery. And as we can see, the internal carotid branches have a black box over them. So we have to see the supraorbital and supratrochlear, which are the main parts. And then here's a better image. And as we remember that the ECA gives out the facial. So the main thing is for ECA is the facial and superficial temporal in this case. Then we have the venous drainage, where we have the facial vein, which is always behind the twisty facial artery. And then we have the venous confluences, and I have some better pictures here to show you as well. So we have the angular, which gives rise to the facial. And then we have the superficial, which joins with the maxillary and then gives us the retromandibular. And then we also have the facial joining the retromandibular. So these two first ones come together in the anterior branch to give us the common facial. And then the retromandibular posterior branch joins with the posterior auricular and then goes into the external jugular vein. Then this is a much better one. So we have the angular, which goes like around here, and then as it goes down to facial, and then it goes into common facial joining with the retromandibular for the anterior division, and then drains into the IJV. And then we also have stuff draining into the EJV. So we start with the superficial temporal and maxillary. They also become retromandibular, and with their posterior division, they kind of go into the back with the posterior auricular, the EJV. Let's see. So here are better pictures as well. As you can see, the angular is right here. The superficial temporal is right here. And again, we talked about the angular going back to facial and then joining with the retromandibular to make the common facial, which is the connection that they have anteriorly, draining into the IJV. And then we have superficial temporal and maxillary joining together, which form the retromandibular. And with that posterior version, it goes into the EJV. So retromandibular drains into both EJV and IJV. It's surprising to me, honestly. Probably should study this more. And again, I go over these just so I don't fail. Anyways, we have the facial via the angular. It connects to the cavernous sinus through the superior and inferior ophthalmic veins. And that's where we have the danger triangle, which is like right here. And cavernous thrombosis is a big thing that can happen there because it drains right into the cavernous sinus, which is like inside here somewhere. I don't even know how to show it. And then it presents with like, fever, headache, periorbital edema, and periorbital because of the angular is like right here. So I kind of can see that. And then paralysis and weakness of the eye muscles again. And then innervation to the face. So we have both facial, which is mainly the motor innervation of the muscles of facial expression, then the trigeminal, which is the majority of the sensory innervation to the face. And then we can talk about it here more, where we have the trigeminal nerve, mainly giving the GSA for the head, and it also carries some SVE, mainly for V3. And then it originates from the lateral pons by two roots, one large sensory root for V1, V2, and V3, and then a small motor root for V3 only. And then apart from that, it's important to know that the V3 is the only one providing the motor from the trigeminal. And it's to all the first pharyngeal arch derivatives, which are the muscles of mastication, mylohyoid, anterior digastric, tensor veli palatini, and tensor tympani. And then we have different branches for the trigeminal. So for the V1 ophthalmic, just GSA, which is sensory, and it exits via the superior orbital fissure, which was the one we discussed in the first one, I guess. And then after that, we have the branches of the V1 ophthalmic. And I like to group them as NFL. So we have nasociliary, frontal, and lacrimal. Frontal becomes supraorbital and supratrochlear as well. Then we move on to V2, and that gives the branches. So it exits via foramen rotundum and then gives off the branches of posterior superior alveolar, which is like right here for your back molars, the zygomatic, and the infraorbital. And those are GSA as well. And then for V3, it's both GSA and SVE, and it exits via the foramen ovale. And then for the sensory branches, as auriculotemporal, inferior alveolar, lingual, and buccal. So far we've had the V1 ophthalmic with NFL, so frontal, nasociliary, lacrimal, with frontal giving the supraorbital, supratrochlear, and that's basically it. There's like other branching, but I don't think we have to worry about that yet. But that was for V1. And then for V2, we have the posterior superior alveolar nerve, the zygomatic, and the infraorbital. So I guess we can have a acronym and we can say EZI is V2. And then for V3 mandibular, let's come up with another one. Temporal, inferior alveolar, lingual, and buccal. So AILB, AILB. I guess that should work. And then we go into the cutaneous sensory distribution of cranial nerve 5. So we have the forehead, scalp, upper eyelid, and dorsum of the nose, which are V1. And then, as we said, those were NFL. And you see the branches of the facial, right, of the frontal from our NFL going to supratrochlear and supraorbital. And then for the V2, we have the lower eyelid, cheek, side of the nose, upper lip, and upper temple. And that's where we get our, what did we say again? It was EZI. So we have the posterior superior alveolar, zygomatic, and then infraorbital. And I feel like infraorbital and zygomatic are the ones that are most superficial. And then, as you can know, or as you already know, PSA is just for the back molars. And then for V3, we have the lower lip, chin, lower jaw, temple, and up to the ear, actually. And as we said, it was AILB. We have auriculotemporal. What was I? That was inferior alveolar. Obviously, that's our main one in dentistry. Then lingual, another big one for dentistry. And of course, buccal, another big one. And here they show the buccal branch of V3 and the mental. I feel like that should have been included there. Anyways, we go on to the facial nerve. And from that, we have two components that emerge from the pontomedullary junction. So where the pons and medulla meet, we have a large motor root for the facial nerve proper, which gives SVE to muscles of facial expression, and then the nervus intermedius, which is taste, presynaptic, parasympathetic, and somatic sensory. So far we have SVE, SVA, GVE, GSA. That's a lot of stuff. That's a lot of stuff doing. It's the longest intraosseous course of any cranial nerve. So that means, it's a big one for us, obviously. And it says through the petrous temporal bone, it turns sharply at the geniculate ganglion. So it gives rise first to the greater petrosal nerve, and then to nerve testopedius, as you can see on the picture on the right. So we have the greater petrosal nerve at first, then the nerve testopedius, and then as it goes down for the tympani, and then it joins lingual nerve afterwards. So the facial nerve, and this is a very what do we call it? Double thing. Where does the facial nerve exit the cranium? And you should say stylomastoid foramen. So for that, it gives off the posterior auricular branch and motor branches to posterior digastric and stylohyoid. And also it enters the parotid gland, forming the parotid plexus. And this is another very testable subject, which is what does the plexus give rise to? Or like what does facial nerve branch off to after the parotid? And temporal, zygomatic, buccal, marginal mandibular, and cervical. So we have the facial nerve, all 6 branches to the face. So to memorize all of these, we have the posterior auricular, temporal, zygomatic, buccal, marginal mandibular, and cervical. And as we said, 2 through 6 were just through the parotid. So people to Zanzibar by motor car is a mnemonic. So we have the posterior auricular, 2 temporal, Zanzibar zygomatic, bi buccal, motor, marginal mandibular, and then car is cervical. And those are the main ones that we should focus on. And then we get to the parotid gland, and it's the largest salivary gland situated anterior inferior to the ear. So it will be right here. Um, it's enclosed in a tough facial capsule, and the parotid bed is called the space that it occupies. And it has the facial nerve, retromandibular vein, which we talked about earlier, and then going to the external carotid. Then the parotid duct is also called the Stenson's duct and goes through it horizontally. It pierces the buccinator and enters the mouth around the second maxillary molar. So that's why when you give an IA, you kind of can see like a little, when you're like opening the cheek, obviously where you're aiming, you can also see a little duct poking out in some people. Some people it's not as apparent, but that's where it will be around. And then they have a mnemonic here as well for the parotid gland. And they are the facial, auriculotemporal, which comes from V3. And then C is carotid artery, external. And then the R, which is the retromandibular vein. So these are the ones related to the parotid gland. So again, that's facial, auriculotemporal, external carotid artery, and retromandibular vein facer. Then we move on to the deep face. I hate deep face. Not that I love superficial face, but I guess we have to do it. How else are we going to fill head and neck? So we have the temporal fossa versus the infratemporal fossa. So the temporal fossa is lateral scalp area, and then the infratemporal fossa is deep and inferior to the zygomatic arch. So that's more of a deeper area. This is going to be the one that we're going to be talking about mainly. So the contents of the infratemporal fossa are the muscles of mastication. So we know temporalis, masseter, lateral pterygoid, medial pterygoid, all the fun stuff. Then we have the maxillary artery, some branches of the maxillary vein, pterygoid venous plexus, CNV3, porta tympani from facial. So let's talk about the muscles of mastication. So they're derived from the first pharyngeal arch. They're innervated by the motor root of V3. And the four muscles again are temporalis, masseter, medial pterygoid, and lateral pterygoid. And as we know, three close the jaw and only one opens it. And as we all know, the one that we focus on is the lateral pterygoid. So let's go through the origin, insertion, and action of each one. So temporalis, which is right here, and start with the origin. There's entire temporal fossa, inferior temporal line, deep temporal fascia. The insertion is the coronoid process in the anterior ramus of the mandible. Its action is to elevate the mandible while the posterior fibers of it retract. So elevate and retract. So here we're closing and pushing back. And then for the masseter, the origin is the inferior border and medial surface of the zygomatic arch. So like right here. And then the insertion is the lateral ramus and the angle of the mandible. That's where a lot of people's jaws hurt. And then the action is to elevate the mandible, and then superficial head assists the protrusion. So main function here is obviously closing. Then we go to the pterygoids. As we know, the medial is the more medial one. The lateral is the more lateral one. The medial pterygoid's origin is the superficial head, maxillary tuberosity, palatine bone, deep head pertaining to the lateral pterygoid plate. So the insertion is the medial ramus of the mandible. So the inner side, I guess, of the mandible. And then the action is bilateral. So it elevates and protrudes. So it kind of like pushes forward and puts it up as well. So closes it. And then unilaterally, it can deviate to the contralateral side. And then we go to the prime mover of opening, which is the lateral pterygoid. And this is the one that, three close it and one open it. This is the one that opens it. So we have the origin, which is the upper head, greater wing of sphenoid. And then we have the lower head of the lateral pterygoid, which is the lateral pterygoid plate. Then the insertion is for the upper head, it goes to the TMJ capsule disc, or disc, I guess I should say. And then the lower head is the pterygoid fovea. And the action bilaterally is protruding and depressing the mandible. So it protrudes, it can push forward with the medial pterygoid, and then it can also depress it so it can open it. And that's the only muscle that can do it. And then some accessory muscles and yield tips focus on are the buccinator, the orbicularis oris, tongue muscles, and suprahyoid muscles. The suprahyoid muscles also assist in opening / depressing the mandible, apart from the lateral pterygoid. And then we have the TMJ movements, a little summary of it. So elevation and closing, we have the temporalis, masseter, and medial pterygoid. And then for depression, we have the lateral pterygoid and suprahyoids, but the main mover obviously is lateral pterygoid. Then for protrusion, we have the lateral pterygoid with some help from the masseter and medial pterygoid. For pushing it back, we have the temporalis, deep masseter, geniohyoid, and digastric, but main retrusion is from the temporalis. And then for grinding, always the pterygoids. Then we go to the TMJ. So it's a modified hinge type of synovial joint. And unlike most hinge joints, it's lined by fibrocartilage, which permits for a hinge and gliding movement. So in terms of the articulation of the TMJ, it usually goes into the like more than 99% of the time, and hopefully articulation is the mandibular fossa and the articular eminence of the temporal bone with the head of the condyle of the mandible. And then we have the joint capsule, which is a loose fibrous capsule that attaches to the mandibular fossa, articular tubercle, and neck of the condyle. So if you can appreciate here on the right, the articular tubercle, which is like at the top, then you have the articular disc, and then we have the joint capsule, and then we have the head of the condyle. And right under, we can see the stylomandibular ligament, which will be important as we talk about it here. So we have the ligaments of the TMJ. So we have the lateral temporomandibular ligament, which is the strongest. Strengthens laterally and prevents posterior dislocation. It has an outer oblique part and a deep horizontal part. So the outer oblique part is the largest, and it limits the opening of the mandible. So this is the outer oblique part of the lateral temporomandibular ligament, limiting the opening of the mandible. And then in terms of the deep horizontal part of the lateral temporomandibular ligament, it limits the posterior movement of the disc and condyle. Then we have some collateral discal ligaments, and those stabilize the articular disc. And then we have the sphenomandibular ligament, which goes from the spine of the sphenoid to the lingula, and it can be damaged during an IAN, which is an inferior alveolar nerve block. And then we have the stylomandibular ligament, which goes from the styloid process, which is that pokey thing at the bottom of the head of the cranium, to the angle of the mandible, and has a thickening of the parotid capsule. And then we have the TMJ articular disc. As we know, there's a superior inferior cavity, as we can see on the right, and then we have the articular disc. And how they move will be discussed in the right next slide in terms of like what kind of happens. So remember that it's fibrocartilage, encasing for the disc. So we have the superior cavity, which is the translation / gliding. And then we have the inferior cavity, which is the rotation slash hinge. So for the 0 to 15 degrees of opening, we have the inferior cavity, and then for the past 15 degrees, we have the superior cavity. And then side to side, just grinding, it's usually like a resting condyle. And then we go on to the innervation and vasculature. So for the innervation of the TMJ, we have mainly the trigeminal V3 acting here. So we have the auriculotemporal, which splits into two roots around the middle meningeal with GSA to the TMJ, ear and temple, and then GVE postsynaptic to the parotid. We also have the mesenteric nerve and the posterior deep temporal nerve. And then in terms of vasculature for the TMJ, we have the superficial temporal, which, as we discussed earlier, is a terminal branch of ECA. And then we also have the maxillary artery branches, deep auricular and anterior tympanic, acting as well here. And we can appreciate more pictures on the right. Then we have the TMJ dislocation. Bilateral is, let's say, somewhat more common, according to them. I don't know who's them, but my professors. And then anterior is the most common. Posterior is mainly uncommon, but anterior dislocation is like the most thing that we deal with in terms of dislocations. And we have here, pictures of it with this displacement with reduction and this displacement without reduction. And then from there, we go into the maxillary artery. And first we have the mandibular part. Second, we have the pterygoid part. And third, we have the pterygopalatine. So for the mandibular part, we have the middle meningeal and inferior alveolar arteries. And then we have, for the second part, the pterygoid, which branches are the deep temporal, mesenteric, and buccal. And then for the third pterygopalatine, we have the PSA, infraorbital, and sphenopalatine. And we can even take a look at the pictures here. So you can see that for we're discussing here I call it the pterygopalatine part, is the third part. So we have the posterior superior alveolar, kind of runs with PSA, I want to say, like the nerve. And then the infraorbital, going with the infraorbital nerve. And it's kind of confusing because, it doesn't, how do I say this? Like maxillary artery branches are not running at the same, like V2 maxillary vein, sorry, nerve. Yeah, we're cooked. Might get destroyed tomorrow. Pray for me. And then we have the pterygoid venous plexus. So we have it located between the temporalis and pterygoid muscles, and it's drained by the maxillary vein. And then we have an anastomosis anteriorly with the facial vein via the deep facial vein, and with the cavernous sinus via emissary vein. So pterygoid venous plexus with the facial vein via deep facial vein, and then cavernous sinus with emissary veins. Then a clinical note for the plexus is that it is at risk of injury, most importantly the hematoma, during a posterior superior alveolar nerve block. So if we're given a PSA, we might have a hematoma to the plexus. And then we have some more innervation with the mandibular nerve, which is the largest division of the trigeminal because it has both motor and sensory functions. And it's formed by the union of a large sensory root and a small motor root, which unite just after passing through the foramen ovale to enter the ITF, or infratemporal fossa. Then we have the individual sensory and motor branches, which are covered in the following slides. So for the foramen ovale contents, we have the mnemonic MALE, MALE, so mandibular, lesser meningeal, lesser petrosal, and emissary vein, connecting the cavernous sinus to the pterygoid plexus. So for the V3 branches, we have the auriculotemporal nerve, the inferior alveolar nerve, and the terminal branch mental nerve. So basically, what we have to focus on here is the parasympathetics to the parotid, mainly with the otic ganglion, but we have to know that V3 does not have any parasympathetics, so the otic ganglion is actually not a part of V3, but it's a part of another nerve. And then we have the inferior alveolar, which enters through the mandibular foramen and travels the mandibular canal, then gives off nerve to mylohyoid before entering. Then we have the terminal branch, which we all love, which is mental nerve. One of my favorites. And then we have V3 branches, lingual and long buccal. So lingual lies anterior to the inferior alveolar nerve, and it supplies the sensory to the 2/3 anterior, or the anterior 2/3 of the tongue, lower of the mouth, and lingual gingiva. And then we have that enters the mouth between the medial pterygoid and the ramus of the mandible, joined by chorda tympani from facial nerve in the infratemporal fossa. And then we have the long buccal, which passes between the two heads of the lateral pterygoid muscles, and then sensory to the skin. That's one of the main functions, as well as sensory to the oral mucosa of the cheek and the buccal gingiva. After that, we have some more V3, mainly the motor branches here and what it has. So we have the medial and lateral pterygoid nerves, the masseteric, anterior, posterior, deep temporal, mylohyoid, nerve to tensor villi palatini, nerve to tensor tympani, and then together the muscles of mastication plus tensor villi palatini, tensor tympani, mylohyoid, and the anterior biliary digastric. You know, they're all innervated in terms of motor via those V3 motor branches. And then last thing to talk about is the chorda tympani and the otic ganglion, since those are some things that they love to talk about. So we have the chorda tympani from facial nerve, cranial nerve number 7, in the inferior temporal fossa, which joins the lingual nerve in the fossa. And then it carries SVA from the anterior 2/3 of the tongue and secretomotor GVE fibers to the submandibular ganglia, and then to the submandibular and sublingual glands. Then the otic ganglion provides the parasympathetic secretomotor innervation to the parotid gland. And those are presynaptic fibers that travel in cranial nerve 9, which is the glossopharyngeal, to the lesser petrosal. And then it synapses in the otic ganglion, medial to the V3, inferior to foramen ovale. And these postsynaptic fibers reach the parotid gland via the auriculotemporal V3. And then at the end, we have some review mnemonics here. So some anatomists like freaking out poor medical students, and that's for the ECA branches. So superior thyroid, descending pharyngeal, lingual, facial, occipital, posterior auricular, maxillary, and superficial temporal. And the main ones that we focused on here were the facial and posterior auricular, and a little bit of lingual, I guess, as well as superficial temporal. Actually, a lot of branches for the ECA we should focus on. And then for the trigeminal exoforamina, we know standing room only, superior orbital fissure, V1, room is rotundum, and then only is ovale for V3, and then rotundum for V2. And then for the all 6 facial nerve branches, we have people to Zanzibar bimotor car, so posterior auricular, temporal, zygomatic, buccal, marginal mandibular, and cervical. And then for the parotid gland contents, we have facer, which we have the facial nerve, auriculotemporal, parotid, external, obviously, and then retromandibular vein. And that's about it.